Hello, everyone. It's Amanda from Intimate Rose, and I'm so excited to be joined by my dear friend and deeply respected colleague, Dr. Sonia Bahlani. Dr. Bahlani is a unique unicorn in pelvic pain for so many reasons. But first and foremost, she trained as a medical doctor. She is a OB-GYN by training, but she also fellowship trained as a urologist. So she's got this very, just such a breadth of knowledge. And then additionally, you just have such a compassionate way about you, and you are so collaborative. One of the first things that I thought when I met you about a year ago, live, I mean, we've interacted via the internet for some time now, but meeting you live, you're just so compassionate and you are so collaborative. You respect the value of pelvic physical therapists, which is, of course, so important to me, but also just other types of professionals. And then you have such an impact on your patients as well. And before I let her talk, I haven't even let her talk yet. Thank you for joining me today.
That was like the most kind introduction. Thank you.
Yes. And I want to show our viewers really quickly here this phenomenal book that you wrote. Dr. Bahlani wrote The Holistic Guide to Navigating Pelvic Pain. And I think that's the whole aspect of it is holistic and looking at the person as a whole entity. So you can purchase this off our website, and we'll link that here in the electronic format currently, and then hardback coming in May.
Yay.
Yes. So there's so many things to discuss, but do you want to just start by telling me about your practice in New York and what types of diagnoses you treat, what kinds of people you help?
Yeah. So thank you so much. Like I said, that introduction was so kind and nice. And it is exactly what I want to put out there when I talk about my practice, because it's really important to me to incorporate both the GYN and the urological aspects of really pelvic pain and really pelvic health. You know what I mean? Because like when we say pelvic pain, then it focuses only on pain, but there can be things like incontinence and all these other issues that can occur. So for me, because of that unique background and that little bit of a different path that I took, I see a lot of patients who have things like vulvar dermatoses, lichen planus, lichen sclerosis, vulvodynia. But then I also see a great deal of patients who have things like interstitial cystitis, since that's what I did my thesis on and most of my research. And then, of course, being in the field, you know that the majority of these diagnoses occur together. So I see a lot of pelvic floor dysfunction, probably more than, I always tell patients when they come into my office and say, I have IC, I'm always like, well, let's rethink that diagnosis for a second. And it's just my passion, you know, I mean, like, I think that we can go down more of a list of diagnoses because there's so many that probably occur together, but I just like to look at the patient as a whole and really be able to look at them and not just say, you're this or you're that, but take a look at what's the biggest issue so that we can kind of get to the bottom of it.
Absolutely. And so many times it's not just one thing, it's 2, 3, or more co-occurring conditions that require the knowledge that you have. Exactly. It's all of these organs nestled very snugly in one small geographic area, sharing fascia, sharing nerves, sharing physiological processes. So it's really impossible to isolate and look at one organ and not the other. So I love how deeply you went into each aspect of that. And so what would a first appointment look like if a patient were coming to see you? And given I know that the evaluation will be different for different diagnoses, but commonly, what are some things that you ask and talk about and then examine and evaluate?
Yeah, it's a long appointment. And I always tell patients that off the bat, like, it is not your regular GYN appointment. It takes a full hour for most of my initial consultations. In fact, probably more, sometimes 75 minutes. Because I like to sit down and what I often do more often than not, I say, if you have any prior records, send them to me before, because I want to review them, because more often than not, you can get bogged down in the nitty-gritty details and miss the bigger picture. And I always want to try to get to the bottom of things, even if I can at the first visit. Like, I like to think that 30% of my patients can get better by their second visit. It's always the more fun visit, because then you're like, oh, I understand how all of this interacts, and I see how I can see myself getting better, you know? Um, so it's about an hour. We really sit down first and we talk about, number one, what brought you in? You know what I mean? So is it pain? Is it pain with sex? Is it incontinence? Is it urgency, frequency? And oftentimes, like you said, it's a culmination of things. And sometimes just even as a patient sitting down and saying, you know what? I have pain, but it's really this persistent urgency that bothers me the most, because often it's not the thing that you think it's going to be. Um, and I tell all patients this before we start too, I'm very type A, and I don't know if you can tell that about me, but I'm like, so when I sit down, I'm like, you're going to tell me your story, and then I'm going to ask you a bunch of really directed questions, because my brain works in this really strange way where I have to hear, and then I sit down and I figure out, like, do you have pain with sex? Do you have pain with initial penetration, deep penetration, urgency? How are your streams? Like, and you can get down and they can be like, whoa, this is a lot of information, but it really sets apart what the primary generator is at that point. And I like to, and maybe this is like a game I play with myself. I don't know if you ever do this, but I will, like, as I talk to a patient, think in my brain, okay, I think this patient is mostly, or I think they're probably suffering from pelvic floor dysfunction or IC. And then when I do my exam, it's almost like a test to see if I was right, And then I take the patient back and we sit down and we do an exam, and it's really like a 3-part exam, maybe 4-part. First things first, I always start by just visually examining, seeing what's going on. Is there any type of visual that I can see even just to the naked eye? Is there white plaques? Is there redness, dryness? And this is talking more about a vulvar exam, but I also see men, right? And so even then you want to take a look at the skin, the foreskin, that kind of thing. And then I do what's called a vulvoscopy or colposcopy, where I take a look under the microscope, because more often than not, you can miss things, and you want to make sure that you're not missing anything to really get to that root cause. And then I will do a digital exam of the pelvic floor, which takes time, right? But first, sorry, I missed this. First, I'll do the Q-tip test to really test the sensitivity of the vestibule. And then I'll do a pelvic floor exam where I take a feel of the muscles, a feel of the bladder. And then generally we can always go from there. I think I'm a less is more type of a person. I don't like to, you won't come into my office and have me place a catheter on the first visit, or you won't come in and have me put a cystoscope in, because I think peeling the onion often takes time. And we also want to make sure that we're really honing down on things and not just throwing meds or throwing different diagnoses or different radiographic studies. So that's kind of what the first appointment is like with me. And then we sit down and we talk about everything. We talk about, how does this relate to that? I try to answer all my patients' questions at the first visit, understanding that they're going to have questions after that, and my practice is very much like, contact me, call me. And I know you're the same way. I would rather hear from you and make sure that we do this right, rather than see you in 6 weeks and say, maybe we didn't do this right. And I think that's also why pelvic floor PT is so important. Like, working with amazing physical therapists is key, because I like you, I have these great relationships, and it's amazing to, sometimes get emails and texts and say, hey, listen, I'm seeing so-and-so, and I think this or that. And it just, I think, is the best to see progress for anyone. That was
I
long.
think, and it was so good, because I think for patients watching this, first of all, you just blew their mind by recognizing that a physician would be in front of them and listening to them and thoroughly evaluating them for 60 to 75 minutes is darn near unheard of. It's hard to do as a practitioner, but you do it. And that is what, because of all the reasons we've described, when it's a pain diagnosis or a multifaceted, ongoing or chronic situation where they need that time, they need to develop that trusting relationship, which comes with time and with feeling heard and understood. And I think that is just so key and so important. And then I do the same thing where, in my head, I have this funny little phrase, I don't know where I got it, where I'm thinking, I'll be a monkey's uncle if X, Y, and Z. And then I go and test it. It's like, correct. or I need to investigate further.
Right.
But yeah, and I love having that kind of relationship too with physicians, where I, as a physical therapist, can say, these were my findings. I'm wondering if we could further investigate X, Y, or Z, or run an additional panel, or,
Yeah.
I'm not sure what's happening with this, but can you take another look at X or Y? So I think that that's so key. And there can be so much learning that happens both from the patient side and from the practitioner side of, if a patient's not in that kind of clinic yet,
Yeah.
those exist, and they need to keep looking until they find that, because that's what gives them hope. It's very frustrating to have gone to gastroenterology and gotten the clean bill of health, and then the train stops and there's no next further investigation, or having gone to urology in isolation, where the urologist is like, bladder looks good to me. And they don't have a solid understanding of pelvic floor. I saw a meme this morning, and I knew we were going to be talking today. And so it really stood out to me of, there was a meme placed by a physical therapist saying that most physicians don't have a good working knowledge of the pelvic floor and its function and its coordination. And I think that's going away. I think that, 12 years ago when I started doing this, I saw that very much. And I had to be giving a lot of education and talks to my physician colleagues. And there wasn't a lot of buy-in, and it was very hard and very frustrating. And I just don't see that anymore. And I think our generation has really flipped that upside down, and excellent physicians like you.
An excellent physical therapist. I feel the same way like you, and that's part of the thing that I think also drew us together, was this concept of empowering patients to have the tools to treat themselves. And it's, one of the reasons that you and I really clicked on the intimate rose end of things. But I always tell my patients, it's my job to give you the tools to treat yourself. You know what I mean? And so often once you're better, I'm like that little voice in your head that says, you know what, maybe I should get my dilator out today, or maybe I should take a warm bath, use a suppository. And those are the kind of things that allow for longevity, so you're not just getting better and then getting worse. But I totally agree with you. And isn't it so funny that we live in a world where a 60 to 75-minute patient appointment seems like out of this world, because we're so used to this 15-minute in and out. And you will miss something in 15 minutes, guaranteed. That's why it's easier for some docs to just send out, because they're like, this doesn't fit into my schedule, which is crazy.
Right. It took conscious effort on your part to make that your clinical paradigm, right? Because the expectation in most facilities is turnover, and all with the intention to help. I strongly feel, nobody goes into medicine, nobody goes into healthcare not wanting to be helpful and to help. It's just that we've entered a phase of humanity where there's just a lot of people that need help, and to create that space is just so amazing.
Necessary, yeah.
Yeah. So I know that you love intimate rose, dilators, and wands particularly. How do you find yourself recommending those in your clinical practice?
So number one, I think that they are an amazing tool, and they work excellently when you provide the right medications in addition to using the right tools. You know what I mean?
Yeah.
And so what I tell patients, and I'm seeing this a lot more with COVID, is that there's this hesitancy to go into a physical therapy office often. And you really can't blame patients. It's often, even walking into my office, or if we do this virtually, there's like and so when I mention intimate rose, I always say, and I always talk about you as a person, because I think it's amazing. You have videos. I mean, if you have a question, you can ask it on the website. You know what I mean? Like, this is awesome. So I always tell patients, like, look, I think you're capable of doing this on your own. It's going to take a little bit of training, a little bit of understanding, but it's about understanding why, when you get frequency and urgency, it's not necessarily the bladder, it's actually the pelvic floor. And what can you do to help it? Do you know what I mean? And even when I examine them, I say, do you feel this? that's actually a trigger point and it's spasming back at me as opposed to a tender point. So we're going to treat those things a little bit differently. Or for a patient who has vulvodynia, understanding how dilators can help with the desensitization. So I always try to like, I have a bunch of your products in the office, but I always tell patients like, you are capable of this, like, because I have tons of patients who have done this on their own, like we're using these tools. So if this is something that you're open to, yeah, because you have to be open to the idea too, to begin with. Um, and a part of that, I think is really important is sometimes like hearing your story too, like kind of how you came into this world, because it's like, look, you can have an issue and you can fix it, and then you can help other people fix their issue. And that to me is just like, yes, the best, most empowering part of all of this. Um, so that's what I'll do. So, I'll recommend, like, if I think it's more of a vulvodynia-like picture, I'll recommend certain dilators. If there's trigger points, I'll recommend the wand. And then, depending on where the trigger points are, or if I do things like injections in the office or Botox, I'll have them bring the products in, and then I'll kind of go over with them, like how I want them to sit and utilize them. And a lot of that, honestly, education has come from your videos. Like I will sometimes watch and say, okay, so that's what she does there. All right, I got it. And then I'll direct them to the video, but it's important because it works hand in hand. And we have had patients we've gotten better together virtually, you know what I mean? And that to me is like just a testament to the fact that it's possible, and that it's more than possible. Like we should all be encouraging this for the most part, because it makes you autonomous.
Which is the goal. Absolutely. It's like we show them the way, provide the resources, whether it's the medications and the tools and all that, and then we're there to support. But by and large, they're managing their life and they're able to do what they want to do.
Exactly. And the truth is we can't prevent things from coming and going. And I always say that, like, look, when you have these diagnoses, more often than not, they're chronic. And so it can get you 100% better. Does this mean it's never going to come back? I can't guarantee you that, but you can't be afraid of it coming back. You have to say, you know what, if it comes back, I have my tools in my toolbox. I'm going to take them out and I'm going to get rid of this flare. And that is just, I think, the best part of all of this, because then you understand, like, it doesn't necessarily mean I have to be perfect. It just means that I have an opportunity to continue to get better. And then the other thing that I remember me and you discussing, because we're both runners, was running. Because I am not, and I know you're not, but I am not the type of clinician that's going to say you can't, because I have a lot of CrossFitters. I have a lot of dancers because I'm in New York and they're all around. I have a lot of cyclists, like professional cyclists. And if I said to them, you know what, I'm just going to tell you, just get off the bike. Just don't, they would be like, I'm getting out of your office. This is ridiculous. And it's really not the right way to practice medicine, because then you're just, if you had a hurt arm, would you say don't lift your arm? No, you wouldn't do that, And so that's also why I really love the products, because I think it's important, after a long ride or after a long whatever, take a warm bath, put in a suppository, use your dilator, help yourself, and it really is so helpful.
Absolutely. I am 100% in alignment with that. I mean, since coming out of school that, obviously if there's a fracture or something bananas happening, then we have to talk to them about restrictions and whatnot, but it's always about finding a way and eventually reaching that patient-centered goal. Otherwise they fire us and we lose the opportunity to help them. And then they feel worse, and then they're back to the drawing board. So I love that philosophy. And you mentioned the injections. Talk to me about Botox and Valium and how you use those, and what kinds of patients are good candidates, and all of that.
So pelvic floor dysfunction is one of these diagnoses that a lot of people, and you're right, now the word is getting out there a little bit more, but back in the day, the word was not out there. And even when I started doing this 8 years ago, patients, and they still do, they consistently come to my office, they say, I have recurrent UTIs, I have interstitial cystitis. What are your symptoms? I have frequency, urgency, my streams are really not that good, I have pain with sex and it really hurts when it's deep. You're like, okay, well, how much bladder involvement is there really, And because the bladder contracts, the pelvic floor doesn't fully relax, it actually spasms, you don't completely empty, and that's what can often cause or contribute to the cycle. And it can often be like 90% of the contributor of the cycle. Um, and so that in and of itself, as many of you know, is pelvic floor dysfunction. But then when I examine a patient, what I'm looking for is a distinction. So when I examine a patient and I take a feel of the different muscles in their levator complex, like the pubococcygeus, the puborectalis, the ischiocavernous, I'm really feeling for, is the muscle tight? Is there banding? Is there a knot? And does that contraction knot spasm back at me? Because I know you know this, but that's the difference between a trigger point and a tender point. And I'm going to treat those two differently. Because if you examine a trigger point and you palpate the trigger point and it spasms back at you, that's an indication that that muscle has a lot of inflammatory cytokines and neurotransmitters in it, like nitrous oxide and all these things. And so oftentimes when you're retraining a muscle, like anywhere in your body, in your neck, in your back, they can be stubborn. So we start with a medication. We start with pelvic floor physical therapy, which is key to retraining. But what if it's just not enough? Do you know what I mean? So what if you're going to pelvic floor physical therapy and you're using Valium suppositories to help keep the muscles relaxed? And you say, I've started coming down on the medication, because who wants to be on a medication forever? And my physical therapist has said, maybe I can come in every other week, but I'm noticing that every time I try to taper off of these things, boom, my symptoms just come right back. Well, that tells you we got to take this a step further. And the step further is what we call either trigger point injections or Botox. And the data for both of these things come from acupuncture data, believe it or not, because it's the needling of the muscle that releases it, right? And so we know that, and that's where all the science comes from. The problem is that needling the muscle can sometimes, so number one, trigger points are composed of medications like lidocaine and marcaine. Lidocaine and marcaine are anesthetics, but they're also anti-inflammatories. So often just by needling the muscle, releasing it, and putting in an anesthetic or an anti-inflammatory is diagnostic and therapeutic in and of itself. If we do that and you work with pelvic floor physical therapy, you have to see the physical therapist after this. And that's what I always tell my patients. If you just inject and you don't see the physical therapist within 48 hours, you're not going to get the benefit of the injection. Because as you know, Amanda, you have to go in there and then you have to keep the muscle released. And that's what ultimately really breaks the cycle, peels that onion, keeps the muscles released. But sometimes muscles are pretty stubborn. And so if you do trigger point injections, I'm not a fan of consistently injecting people, because when you put in needles, you can form scar tissue in and of itself. So a great tool that's come out that a lot of doctors like me use is Botox. And Botox is a neurotoxin. It works at the acetylcholine junction, the neuromuscular junction. I don't like to use the word paralyzed because it scares people and they're like, whoa. But if you use the right amount, just like you do in your forehead, it keeps these muscles released for a period of 3 to 6 months. And that in and of itself is huge. But again, you have to see the physical therapist after it. Or for some of my patients who do this out of state, they will use their Intimate Rose products. You have to use the wand. You have to keep it released. And with Botox, you can't use ice or heat. So, you got to be very careful with that kind of thing. But I would say Botox, trigger point injections, they work beautifully when done correctly, because people will always ask me like, do people flare after that? I always say, if you pick the right patient, no, they don't flare. I often do my injections with pudendal nerve blocks, because you cannot just look at muscles, like you said, without looking at nerves, right? And this is often a neuromuscular phenomenon. So if we're not taking care of the pudendal nerve at the same time and bathing it at the same time as the muscles, you won't see oftentimes the amount of relief that you can. So I think that's key too. But I think injections are a great tool that we have. The needles are so tiny, people get scared, like, oh, they're big. I promise you they're very tiny. And I promise you we wouldn't do this if it didn't help. But yeah, I think it's a great tool.
Absolutely. And thinking of all the good that can be done with retraining the muscle in that downtime, in that window, to help fully, get to the point where they have better neuromuscular control, as you just noted. And it's like taking the load off
Yeah.
just for a bit, so that their brain and their muscles can reconnect in a more stable fashion.
Yeah, absolutely. That's exactly what it is. And that's exactly why it doesn't work alone. That's exactly why we have to work as a team approach, because otherwise you're just masking. You know what I mean? And you're not retraining. And that's the key to all of this.
That's great. I love that. I love that. So with a visit like that, you would have evaluated them and then they've come back in for follow up. And do you see them, like, do you check in via email or text, or do they come back in for reassessment, or what does that process look like?
Yeah, I like to have them come back in because I like to re-examine the patient, and I do always speak to the physical therapist to see what they're finding. And I often have physical therapists, especially in New York, who come to my office for injection. Like they will come during the injections for a patient, because I always say, look, there's no ego involved. I'm not in your pelvic floor as much as the physical therapist is. They're in there all the time. You know what I mean? So I don't want to miss the spot. I don't want to like say, okay, here I got this. And then oftentimes, this with like the way that we're looking at the pelvic floor musculature, what I call pubococcygeus, you may call the posterior part of the puborectalis. You know what I mean? And so I don't want to like confuse anything. So I bring patients back for a follow-up, and I will often start, and I'm not a medication pusher by any means. And this is why I think it's important to kind of understand how medications work adjunctively, like as helpers, but it's always, in my opinion, a raft to get you to that next spot.
Yes.
So even if we're using things like a Valium suppository, that's not a forever drug. Do you know what I mean? But it gives me a clue, like, okay, if we do the Valium suppository and pelvic floor PT and you're 90% better, well, then guess what? It's coming from the pelvic floor. You know what I mean? Whereas like if you're 60% better and you say to me, but you know what, the only thing I'm really feeling this pain with bladder filling and I'm still having, then we have to assess the bladder a little bit more. Do you know what I mean? And that's why I think using these things as tools is really key. So then I'll reassess the patient. And then I'm always a big believer, even with injections, of less is more. So I think that, number one, like we talked about before, you have to be mentally there. You have to understand the science behind it, like what we talked about, trigger versus tender. Because otherwise these things can flare you, and we don't want that to happen. And then I'm also a big believer in utilizing things like your tools, like the exercises that you do, things like yoga, things like mindful meditation, because we can together fix this, right? But if you have some sort of stressful event that incites the entire cycle, it's not because it's in your head. What do people do when they're stressed out? Clench that pelvic floor, right? Like we clench our jaw, same thing. Then I've only done half my job. Do you know what I mean? Because that I haven't given you the tools to kind of help the other way. And that's why that's really key for me too. And then what you do a lot of, which I love, is the breathing. You have to understand how breathing is going to affect all of this. Because if you don't, you don't understand the involvement of the vagus nerve, of diaphragmatic box breathing, like you will just end up getting, a little bit better, but not better to the extent that you can, and not preventing it from coming back as you can.
Absolutely. Absolutely. Yeah, it's addressing all of the mechanisms, all of the drivers, as you mentioned.
And the other thing, I forgot to say this, that everyone always asks me for injections. They say, Dr. Bahlani, can you just put me to sleep? You're a surgeon, just put me to sleep. I don't want to be awake for this. And I always tell them, it's like going on a car ride without a roadmap. You know what I mean? It's like being like, because when a patient is under sedation or under anesthesia, what happens to their pelvic floor muscles? They completely release.
Everything's fine.
fine. And so when you hear about these scary things where people will say, oh, I heard about, my friend got incontinence after she had an injection. Well, if you're not doing it in real time to see what's going on, you're going to get a complication, right? So that's why it's important for patients to be awake during this procedure. It's something I believe strongly in. And it's something that, I always tell my patients, like, if we want to do this the right way, I promise you, I know it's like you can get afraid of a little pinch, but the relief that you feel after is like nothing compared to it. Do you know what I mean? And oftentimes, we can give patients something in the office just to help, with the like anxiety that can be produced with it. I think that's great, but I definitely don't recommend like completely being asleep because you'll miss something.
Absolutely. Yeah. Being cognizant of what's happening, and that helps the relearning process too. And I love that philosophy, because it would be hitting the easy button just to take a little snooze and wake up and have the hard work have done. But so much learning on the collaborative effort of between patient and a provider can happen in that way too. And then, better plan of care afterwards as well.
Yeah. And it's amazing because sometimes you'll do injections in the office and patients are like, oh yes, that spot right there is exactly where I feel it. And you're like, boom, and it releases and they're like, oh my God, like this is crazy, but like,
Yes.
because then they're leaving without pain and it's really important and necessary.
It's so true. When I release them, I do a manual technique, obviously, and it's like the best feeling of, ouch, that's it. That is exactly it. I've never had anyone identify that 1 minute release, and so much better afterwards. It's the best.
It's the best. And that's why I love the wand too. I always tell them at their injection appointment, I say, bring your wand. I'm going to show you exactly how I want you to use it right now. You know what I mean? Because sometimes then they're like fiddling with it. They're not sure. I'm like, okay, here you go. You feel that spot that we just got right there? That's the spot you're going to get for the next 3 days,
And that is why your patients love you.
Oh, yeah.
Oh, that's wonderful.
Stuff in this field.
Yes. Is there anything else that you would like people to know about your practice or about your philosophy for pelvic pain?
I think that number one, people use the term root cause all the time, and I think it can be misleading sometimes because oftentimes the root cause is multiple causes. So in my practice, I would say, I see patients from everywhere. So I'm based out of New York, but I see patients from all over the United States. And even virtually, we're able to get a lot done because, like I said, when you target and understand symptoms, you can actually target and understand what we call etiology or pathophysiology, like where is this coming from? And then oftentimes to get to that 100% better or the 99% better phase, there's going to be bad days. Sometimes there's good days, sometimes there's bad days. And that doesn't necessarily mean that it's not working or that we're not doing the right thing, but that we have to really go through that to peel that onion, to figure out what's the next layer of this that we're missing. So that you're not just ending up on, because the worst thing to me is the patient that walks into my office who's seen 10 different providers, who's on 18 different medications and still in pain, and then you're like, all right, now we have to, you're on Lyrica, nortriptyline, this, that, and then like, now what do we do? Where do we go from here? Whereas the answer can often be simplified when you use diagnostic and therapeutic strategies. Although there can often be times where it's not so fun, it does have a reasoning for it.
Absolutely. And it's part of the means to reaching that patient-centered goal. I think that's I love the way you outlined that, is that not all the days are going to be a perfect trajectory of improvement. And there are little valleys in it, but on the whole, it's working towards that 100%, like you mentioned.
And then it's the best. And it's the best when you have a patient walk in and say, I'm having all this great sex, because, the absence of pain is not pleasure, right? So we're going to get you out of pain, but we have to also give you the pleasure. Or when a patient comes in and they're like, I feel great. Like, I didn't even want to come in to see you. Good. I don't want you to go to see you. These are my favorite appointments. But yeah, I think that it's been a great trajectory, kind of being in this community with people like you and people who understand and feel the same way towards it. You know what I mean? Because that's the coolest part, I think.
I totally agree. We've got such an amazing little planet that we are creating and actively participating in, and I'm so thankful for you, and I'm so thankful for all the great education for people watching this. If you are not following her, Pelvic Pain Doc on Instagram and Twitter as well.
Yes, Twitter as
Okay,
well,
great.
and Facebook as well.
And Facebook. So we'll link all that here because the information that you put out is just so beneficial and so kind. And I think it's the delivery too, right? It's awesome education and how we deliver it, which you do so well.
Thank you. That means so much to me coming from you.
Oh, well, thank you so much for being here. We're going to link all of your places for people to find you. If people are looking for a provider, perhaps they can look up your clinical information as well. And I know that I've sent people to you for consult, and this awful disease has brought us a better understanding of how we use our tech and how we can consult. And for that, we are gonna take that positive and use it.
There is
Yes.
a lining there. I think telehealth is something I'll keep forever because I think it's just so important. It's the wave of the future.
It's here to stay. Absolutely. Well, thank you so much.
All right. I'll talk to you guys later.